organization, the UAE Genetic Diseases Association, for their invaluable support of this wonderful initiative and for generously sponsoring the Conference of Iraqi Medical in UAE. Dear friends, I stand before you to discuss the remarkable journey of Iraqi doctors in the field of surgery and medicine, highlighting our successes and the importance of maintaining our integrity as healthcare professionals while resisting the pressures of commercialization. Iraqi doctor, now, our topics are the following: historical context, pillar of successes, danger of commercialization, strategies to resist commercialization, and I will show you some of our work by clinical example. Iraqi medicine has a rich history dating back to ancient civilization, known for their advancement in healthcare. Our country has produced numerous eminent scholars and healthcare professionals who have laid the groundwork for current medical prowess. Despite challenges over the years, Iraqi doctors remain resilient, showcasing exceptional skill both locally and internationally. In recent years, many of our fellow practitioners have relocated abroad, achieving great success and recognition. Their contribution in various specialties have often earned them esteemed position in global medical communities. This raises the question, what is the secret to our success? Education and training, community and collaboration, adaptability and innovation. Finally, the commitment to patient. Our dedication to patient care is paramount. Practicing medicine with compassion, ethics, and a focus on well-being of the patient ensures trust and respect within communities. As we celebrate our successes, we must also address the growing issue of commercialization in healthcare. The temptation to prioritize profit over the patient care can compromise our values and expertise. Commercialization leads to a focus on quantity rather than quality. Commercialization leads to focus on quantity rather than quality. Patients may undergo procedures, surgical or unsurgical, without any benefit, or receiving medication or even investigation which has negative impact on patient care. Patients usually seek healthcare based on trust. When practice becomes overly commercialized, it can create skepticism regarding the motives of healthcare providers. This origin of trust can diminish the doctor-patient relationship, and this is catastrophe. كلمة الطبيب كانت تكاد أن تكون مقدسة. Compromising our ethical standard for profit undermines our oath as medical professionals. Maintaining integrity is essential for the longevity of our practice and the welfare of our patient. Now, the strategy to resist the commercialization are to focus on patient-centered care, promote ethical practices, encourage public awareness, support professional associations. And now I will show you our work by clinical example. You see, when you see such case, what is the easiest answer? Is to amputate. And this is easy for doctors, for nurses, for the staff, for the hospital, for everyone except for the interest of patients. If you want to uphold the ethical code, then you must keep the patient-based interest in mind. So we convent everybody involved on save the left food of this patient. Especially, she lost her right foot at the site of the accident. Now, you see, this is the result. As you can see, the food is saved. And with the help of post-operative rehabilitation, patient managed to walk using her left foot and artificial leg on the right side. Another motor cycle accident, and in such case, don't be scared. Go treat the patient, examine the patient thoroughly many times, and you may find solution for good management. Following motorcycle accident, the patient sustained severe head and facial injury. He was brought to emergency of our hospital with loss of consciousness, fractured skull, fractured maxilla, fractured nasal bone, and with the restoration and the result, the successful result was due to multiple disciplinary team efforts, such as the emergency unit and the staff, UAI, intensive care, anesthetist, and neurosurgeon, and the dental department. We could arrive to restore the function and the appearance of this patient. Another. This some cosmetic nose rhinoplasty before and after. Other, please. Other. Facelift, cervicofacial lift before and after, and you see the patient after this operation looks more than 10 years younger than before. Complex abdomen with a huge and major surgery, we could have and get this result. She was mother of 14 kids. And please, another. This is the lateral view, another.
You have a 3-minute, doctor.
Okay. This classical abdomen. Another, please. Too far? No. In conclusion, the successes of doctors in surgery and medicine is a testament to our resilience, commitment to patient care, and unwavering the ethical standards. As we continue to excel in our profession, let us remain vigilant against the commercialization of medicine. By prioritizing compassion, integrity, and collaboration, we can ensure that our contribution to healthcare truly reflects the noble calling of our profession. Thank you very much.
Thank you. Thank you for nice presentation. Thank you, Prof.
He is a senior consultant working with us in Mediclinic Waker Hospital, Mediclinic Parkview, and Mediclinic Dubai Mall also. He is actually got the award of the Rheumatologist of the Year 2024 for his biggest achievement in initiating the rheumatology guidelines. Pleasure, Dr. Mustafa. Thank you.
This one for you, sorry.
This one is not working.
Assalamu alaikum, colleagues, and my pleasure to be here, actually. It's an honor for me, actually, to follow Professor Abdelbaqi Al-Khatib, our great mentor in the medical school. And the great slides you show are really very impressive, Professor Abdelbaqi. I'll be talking, I'm going with the theme, actually, of the meeting about the updates. So I'm talking about the biologics in lupus and how much it has changed the prognosis and the setting of the lupus and its patients. And actually, I have put down this photo, which represent actually what you can see in a lupus patient. Usually these are young females in their fertile period of life, and usually they are good looking, actually, the lupus patients. Sometimes they call it the pretty woman disease, which is true, actually. And you can see the main features in lupus in the slide is showing the butterfly rash and also the lymph nodes in the neck. And then the blood picture showing the changes there. Mainly it's, cytopenias usually, leukopenias, lymphopenia, thrombocytopenia, and others. So by definition, SLE is autoimmune disorder characterized by antibodies to nuclear and cytoplasmic antigens with multi-system inflammation and variable clinical manifestations and relapsing and remitting course. And actually, it is considered as the module of the autoimmune disease, SLE, because it's the most common autoimmune disease which carries the highest number of autoantibodies. Too much background noise. Okay. And as mentioned, 90% of affected are females, frequently at childbearing age. And this is the wolf. Actually, as you know, lupus comes from the Latin word lupus, which means wolf. That's why they call it مرض الذئب أو داء الذئبة الإحمرارية. But actually, it's been harsh, this name, so it has been changed recently to the butterfly disease. So now we call it داء الفراشة. And as you see, because typical butterfly rash, so we call it داء الفراشة rather than داء الذئبة, which is kinder also for the patients. And the manifestations are so variable in lupus, causing multiple organ systems, and 74% of patients develop moderate to severe disease. So the majority of the patients will have moderate to severe disease. And you can see on those photos how it's affected these manifestations. It's starting from here, from the left, the malar rash, which is typical butterfly, presence of mouth ulcers, which is a main feature in lupus, presence of photosensitive rash. Most lupus patients, they have to wear sunblocks before they go out because of photosensitive rash. The discoid rash and the subacute cutaneous are distinct varieties. Raynaud's phenomena, most of the patients will have Raynaud's, and they have complaint of cold hands and cold feet. Arthritis, which that's why these patients are brought to rheumatology, because of arthritis mainly. Unfortunately for them, it's unlike rheumatoid. It is non-deforming, non-erosive, non-destructive, so non-erosive arthritis. Cutaneous vasculitis, again, is a main feature of the disease. Hematological abnormalities, leukopenia, thrombocytopenia, cardiovascular disease is important, all the layers. Some patients present with pericarditis, pericardial effusion, and myocarditis with conduction defects, and endocarditis. Pleuritis, pleurisy with pleural effusion, again, one of the common manifestations of SLE. Renal, this is actually what we worry about. We always check our patients if they have any albuminuria, which is a bad sign, actually. Almost 50% of patients will have some degree of albuminuria. Neurolupus can be mild, like migraine, up to strokes. The strokes are usually due to cerebral vasculitis or could be due to antiphospholipid syndrome, which we find in about 15% of lupus patients, antiphospholipid antibodies, so they are liable to develop strokes. Alopecia, of course, it's a major issue with them, and it's a good sign, actually, of disease severity. When patients recover, one of the earliest things they will notice improvement of hair growth. So to diagnose SLE, in rheumatology, we follow guidelines. The guidelines are those of the ACR, American College of Rheumatology, and European League Against Rheumatism, the EULAR. They have updated the criteria, the last one done in 2019, and the classification requires a positive ANA. You cannot diagnose lupus without a positive ANA. So this is a must, actually. And if that's present, then there are 22 additive weighted classification criteria are considered. It covers different domains and 3 immunological domains, including antiphospholipid antibodies, the complement proteins, mainly C3, C4 is very important in our work, and the SLE specific antibodies. So the criteria are assigned like points, 2 of 10, and patients need 1 clinical criteria, 10 or more points to be classified as lupus. So EULAR treatment, the European League Against Rheumatism guidelines, these were 2019, but they were replaced now with the next slide by the 2023. And you see the guidelines, actually, for treatment of non-renal SLE. You can see disease divide into mild, moderate, and severe, first line, second line. And then if you come to medications, HCQ, hydroxychloroquine. Hydroxychloroquine is the cornerstone. There should be no lupus patient without hydroxychloroquine. And then we proceed to others. Steroids, majority of patients will need steroids. But our aim is to reduce the dose to minimum or to get them off steroids. Then comes the immunosuppressants, and I don't like this term, I call them immunomodulators. Immunomodulators, methotrexate, azathioprine, and mycophenolate. So these 3 drugs are really valuable drugs. Most of my patients, actually, they are on hydroxychloroquine and azathioprine. And those with more severe, they will go to the mycophenolate. And then we've been lucky with the advent of biologics in the last decade. We have now 2 approved biologics. Unlike rheumatoid arthritis, we have plethora of biologics. In lupus, only 2 biologics got the FDA approval in the last decade. Belimumab and the anifrolumab. And then CNI, which is calcineurin inhibitors like cyclosporines. If you go to the severe there, you'll find cyclophosphamide. We give cyclophosphamide as infusions, especially in renal lupus and in neurolupus. Rituximab, this is valuable, actually. This is the oldest biologics, but still it is not FDA approved. We still use it as off-label medication. So there are also some new recommendations in 2023 for non-renal. We are aiming for a low-dose steroid. This is very important. In the past, most patients became cushingoid. However, now are keeping them on low-dose steroids. So the recommendation by the ULR to use a lower steroid maintenance target, less than 5 milligram, and then withdraw when possible, and steroids should be applied as a bridging therapy. We know long-term exposure has a major risk for patients, what we call the cumulative damage. We have a cumulative damage index in lupus. And then the recommendation here, initiate immunosuppressive drug early to avoid long-term exposure to steroids. And now the new one that is not mandatory to use conventional immunosuppressants before introducing biologics like belimumab. Consider biologic patients with SLE not responding to HCQ steroids or those unable to reduce steroids. This is a good advice, but in real life it is not applicable because the insurance companies will never approve a patient to start lupus patient on a biologic before going through the full set of immunomodulators. And this is just to show you this slide, although it's crowded, just to show you how many biologics being tried and failed. There are so many biologics tried in SLE, but they failed actually. So only these two in bold letters, the belimumab, which is the BLISS, which is B lymphocyte stimulant suppressor, and then anifrolumab, which acts on the IFNAR, interferon alpha receptors. These are the only two approved. And what's going on with mortality in rheumatic diseases, you can see that lupus mortality has not much improved before the advent of these biologics in the last 20 years. These are the figures from the British registry, and you can see between 1999 and 2014, so over 15 years, rheumatoid arthritis mortality has improved. So there is marked improvement of mortality in the last 15 years. However, when we go to the SLE, there is not much improvement. There is improvement, but it's only minimal, statistically non-significant. But that was till 2014, actually. After that, after 2014, then we are having now these approved biologics, which definitely have altered the mortality in lupus patients. I'll give you an example, anifrolumab, the alpha interferon receptor blocker, demonstrated comprehensive control. If you look on the right, 53%.
Doctor, here. You have 3 minutes.
Sorry?
You have 3 minutes. Here.
You're talking to me.
Yeah.
Okay, sorry.
You have
I was looking up. Okay. Now finish, almost finished, only 2-3 slides left. So you can see the achievement now with anifrolumab, that 53% more patients experience reductions in disease activity, including lupus nephritis also. And also, in that study called TULIP study for anifrolumab, 72% of patients achieved sustained oral corticosteroid reduction. Dose has been reduced to less than 7.5 milligram. So in summary, this is my last slide, Dr. Kauthar, okay? The last one. Yeah. We say that biologics in SLE are here to stay, and they have altered the disease severity, prognosis, and mortality. And now we have increasing number of lupus patients under biologic can start to experience a better quality of life with less lupus flares. And the approved biologic list is expected to grow over the next decade. Just to mention that rituximab actually has been there, this biologic, from the 70s. This is a 50 years old biologic, was used for the treatment of lymphoma, and it was highly successful in treatment of lymphoma. But in the early 80s, actually, Professor Eisenberg from UK, he was the one who noticed that a patient with lymphoma and rheumatoid arthritis, when they received rituximab, rheumatoid arthritis has almost gone. went into remission. From there, that was the start of using rituximab. Rituximab, we use it in rheumatoid arthritis, but also in lupus, it's highly effective. Renal lupus, mainly a renal lupus, but still it is off-label. And thank you.
Let me introduce the next presenter. It is amazing session and excellent speakers here. Okay. The next one, Dr. Falah Al-Khatib, consultant clinical oncologist, fellow the Royal College of Radiologists, senior consultant at Al Zahra Hospital Advanced Care Oncology Center, Dubai, Emirat. His presentation will be management of breast cancer, past, present, and future. Welcome.
السلام عليكم بسم الله الرحمن الرحيم. شكرا دكتور للساينتفك كوميتي دكتورة مريم للدعوة. So which one to move forward? Which one moves forward? Okay. Now, talking about breast cancer, which is a major issue, psychological, social, clinical as well. And it's a very old disease. This is the first documentation of a breast cancer in the ancient Egyptian literature about 5,000 years ago. But I'm not going to dwell on this history or whatever. I will go straight to our current situation. This is 2020 international cancer incidence, both sexes, all ages, and you can see that breast cancer is number one at the top, about maybe 12% of all cancer cases. But in mortality, it's number 5. If we go into women, breast cancer then is a major issue, is about 25% of all cancer cases all over the world. If we come to the United Arab Emirates, then the number, what is it that? This is in the United Arab Emirates. Cancer of the breast, again, both sexes, all ages, it is about 25%. But if you look at women, it is about 40%. And actually, in our practical daily encounter, treatment-wise, breast cancer maybe takes about 60% of all our daily work. Here, internationally, of course, this is a frequency chart, it's not an incidence, because incidence increases with age like anywhere else. But because of the population setting in the Emirates pyramid of the nearly 40% of all population, 75% are less than 40. And the people who are, the patient who are more than, the population who are more than 60 is only 8%. So therefore, we see, as it was mentioned in one of the lectures, that we see diseases 10 years younger than the Western or developed countries. This is not incidence, this is a frequency, because this is the making of the population. All our population here are less than 50. And here, if you can see, the frequency, most of the cases that we see are less than, nearly 70% are less than 50, and about maybe 30 or 40 less than 40. So we are dealing with a very young population that's genetically different from what we see in the West. Now, the detection of breast cancer is easy. It's either self-presentation. A woman feel a breast lump, or she has a nipple discharge, or she has a lymph node in the axilla, or by screening. And unfortunately, we don't have an organized data screening program, but we have ad hoc screening here. Women go, when they go for different issues during their journeys to visits to their clinics, they do screening, and we start seeing a lot. When I started here 40 years ago almost, there were only few people had screening. But now we see a lot of patients coming through screening program. And the screening is either by ultrasound and mammogram. This is the standard, 2D or 3D, or now we have with contrast, mammogram with contrast, or very lately MRI has taken a lot of advantage in that it gives us an idea about both the breast and the multifocality. And here we have young population, dense breast, larger breast, during lactation. So it's difficult to find them with ultrasound or mammogram. And soon probably we'll drop the mammogram and we'll go straight to MRI in the future. And then, of course, with the artificial intelligence, things will change. Within the next maybe 5 to 10 years, all these modalities disappear, and then we'll have something totally different. This is the ultrasound. You can tell that this is what we call it on the scale of BI-RADS, those who are with the X-ray experience. BI-RADS 4, that is almost 80%, we can say that is cancer. The other one, the mammogram, again, you can see the calcification there, microcalcification, and the node there. And this is, again, you can tell with these two modalities, you can say this is maybe 85% a malignancy. And now, of course, the new modality of PET-CT, and again, you can see the disease in the breast and in the axilla, where you have the lymph node. And this is, has been added, especially when we suspect a high incidence of distal metastasis. Now, the next issue is we need a biopsy. So far, we cannot do without it, because the tissue is the issue. If we don't have biopsy, then we can say it's cancer 100%. This is a trend that the woman goes to a mammogram, to get mammogram or ultrasound, and somebody goes there and say, okay, this is cancer, let's do surgery or whatever. Now, without tissue, we cannot say. It's 100%, we need tissue. And the tissue can be, we need it from the core biopsy from the breast, we need it from the axilla, whether it's palpable or by imaging. And then it's not only that, but we need some certain criteria like estrogen receptor, progesterone receptors, and HER2 receptors. And then we need the Ki-67 score, which gives you some idea about the activity of the disease. And of course, now we have molecular and genetic testing like BRCA1 and 2, and there are many others that we will see. And without this ER/PR HER2 markers, we cannot treat breast cancer. It's not possible these days. And then we need, of course, the TNM classification, and this we get from maybe the PET scan and so on. And in the future, maybe sometimes in the future, maybe 10 years from now, then we don't need biopsy, but we'll go for other things like circulating tumor cells or protein circulating, tumor circulating proteins, and then tumor markers that we find with the blood tests. This is the genetic testing, and it can show you, molecular, and it can show you 4 subtypes of a breast cancer. There is luminal A, there is luminal B, and there is HER2 enriched, and there is a baseline, which is triple negative. And each one of these has different treatment, totally different treatment. You cannot give one simple treatment for this group of people. And now we have the molecular, and you can see the number of the number of targets in the cell that we can hit to treat breast cancer. There are about 20 different options in this situation. So here, once we get the mammogram, ultrasound, when we get the biopsy and diagnose that this is 100% malignant tumor, then we need the MDT, which is the multidisciplinary team. And without this, you cannot go further, because there are so many options that I'll light later on, and then you cannot do without multidisciplinary team. Anybody, it's not a one-man show anymore. For the surgery, we have different options, and we have gone through transformation from the early last century, when we had the radical mastectomy, which called Halsted, that takes everything with the pectoralis major muscle for the surgeon who are in the audience, and leave the chest with only ribs and some skin, and then went further to extended radical mastectomy to take the lymph nodes from the internal mammary chain, but that was dropped later on, and then to modified radical mastectomy, where we leave the pectoralis major behind. And now we're coming down to conservative management. We do only remove the tumor with safe area, and then we do, and now in the trend, there is probably no surgery for the breast. We are already seeing it in other organs, like in the rectum. With immune therapy, we give them treatment, and therefore it disappears for certain subtype, and therefore no surgery for this. And maybe we are going into that direction in the future for the breast as well. And for the axilla, we used to do axillary clearance, and what was extensive. We removed 30 lymph nodes, and with all the complications, I didn't put many pictures because the limit of the time, of edema, of difficulty movement, of a lot of problem, neuropathy. And now we come to sentinel lymph node. We only take 3 or 4 lymph nodes without much damage to the tissue, to the axilla. There is a latest study that published just in the last San Antonio, which was in December. There's no axillary sampling at all. We just do remove the breast for certain, of course, for certain group with very early disease, no lymph node clinically and by other modalities.
You have a 3-minute,
For radiotherapy, we have this radiotherapy. It is to chest wall or to other areas. We went from 8 weeks to now we're doing maybe only 3-4 weeks. And these are the systemic therapy, and you can see there are a lot of options between hormone therapy, chemotherapy, immune therapy, and a combination of all these, or target therapy. And this is in the last century, you see, in the last 10 years, we've seen much more invented, more drug than all the 90 years we had before. And these are the options. When you come to the MDT, sit to talk about, discuss how to treat breast. Where do you start? With surgery, like we did in the old days, surgery, chemotherapy, adjuvant radiotherapy, hormonal therapy, and that one size fits all, which is no more the right position. But then you can see there are 9 options for each patient on how to treat this. Surgery first, chemotherapy, new adjuvant chemo, no surgery, and there are many. So with this, you need this. Without MDT, you cannot move. And the message in conclusion, we need 3 things. Early detection, which is the most important issue. Then there is a prevention that comes later, but early detection is one. And then precision, personalized medicine, because each patient, there are no two patients are alike. And the third one is the multidisciplinary team. And thank you.
Thank you. Thank you, Prof, for this nice presentation. Thank you.
Yeah, thank you so much, Dr. Falah. Always enjoying, whether in the lectures or in MDT, you are always the key role there. See, have the pleasure to introduce one of the leaders of rheumatology in UAE, Dr. Abdul Amir Rashid. Abu Naila. He is the consultant rheumatologist in Canadian Hospital, and he will present about the most recent advances in the management in rheumatology.
Thanks a lot.
And just one, after we finish, this will be our last talk, then we'll have 10-15 minutes for Q&A.
Assalamu alaikum. Assalamu alaikum. First, thanks for the committee for inviting me. Thanks a lot, especially Dr. Yahya Kewan and Dr. Mariam. I want to present one, it's a common disease, but the problem is silent. When there is symptom, which means that there is a disaster to the patient and even impact the families and even the government. My talk regarding the osteoporosis. Osteoporosis characterized by low bone mass, microarchitectural disruption, skeletal fragility resulting in decreased bone mass and increased fragility and lead to a fracture. Epidemiology. A third of women, they have fracture or they have osteoporosis more than 50, and 1 in 5 men over 50, they have osteoporosis. The problem is 15 to 30 men and 30% to 50 women suffer from fracture in their lives. Men are twice likely to die after hip fracture. More than 25% they die. More than breast cancer, more than even heart attack. Men are 50% less likely to receive treatment because usually we concentrate on the women, but the men also they increase no incidence of osteoporosis. Maybe because most probably due to hormonal and sometimes lifestyle. The problem of the disease is silent. The patient came with complication of fracture. Usually lead to deformity and it even sometimes decrease the height. The vertebral fracture is the most common. It occurs around 2/3 of the patient. And hip fracture, it affects more than 15 of women and 5% of men by 8 years of age. The risk rise exponentially with the age. But the rest, usually it's occur during time of menopause. How to diagnose osteoporosis? We have bone densitometry or DIXA study. Usually we need to do the DIXA study after 56 age in women and after 70 in men. But if there is risk factor, for example, history of fracture, hormonal deficiency, or any patient takes steroid, or he has history of rheumatoid, we need to do DIXA study as early as possible after 50 to 69. How to diagnose? As I said, there is a DIXA machine. Now it's available in most of the hospital in UAE. This test take about 10 to 15 minutes, even less radiation. And usually it's covered by insurance. We diagnose in patient with fragility fracture, particularly at the spine, hip, breast, or humerus. How to diagnose this? If there is a patient with fragility fracture, or we depend on the T-score, if less than 2.5. T-score, the incidence, this we see the bone density according to the young age. T-score, if -1 to -2.5, it's called osteopenia. It's needed treatment if there is any risk factor. But if patient less than 2.5, which diagnosed osteoporosis. If there is fracture, which called severe osteoporosis. In patient with osteopenia, we need to apply for a FRAX assessment. Assessment the probability of fracture of hip or other fracture during the next 10 years. Okay, if there is 3% percent of hip fracture need medicine. This is the FRAX. It depends on the age of the patient and the weight also, and the risk factor. If he has rheumatoid or steroid, increase the risk for get fracture during the next 10 years. Any patient with before diagnosis of DICSA study, we need to assess the patient. We send for all the function of the liver, renal function, complete blood count, and we need to send for parathyroid hormone or even protein electrophoresis. And also hormonal study. In male and female, we need to check for testosterone, for estrogen. Management. At first, we need to discuss this with the patient, because most patients, because of the silent disease, they refuse to take medicine. I have many patients. Lastly, before 1 week, one patient came around 8 years. Till his age, he didn't take any medicine for osteoporosis. Unfortunately, he falling down simple from the chair. And he came to me with pain of the knees, but during examination, there is a fracture of head of humerus, of hip, sorry. So management first, we need to first lifestyle measure, adequate calcium, please. The calcium, usually we need at least 500. So the food with the tablet, we need to take at least 1,000. And vitamin D 800 international units. So we can tell the patient that you need 1,000 from this and 1,000 from vitamin D. Weight-bearing exercise, very important to encourage the patient for walking, swimming, or even playing tennis, anything. At least 5 times a week. Also, we need to tell the patient to stop, if he smoke, to stop smoking and decrease the alcohol. Some medicine decrease the bone density, like steroid is very important, because we are the rheumatologists, we use steroid too much. But nowadays, we not allowed to use more than 7.5 per day. And also, PPI for the stomach also lead to decreased bone density. So the candidate for therapy, if women more than 65 and men more than 70, we use DICSA study. If the T-score less than 2.5, or he has a fracture, we diagnose him as osteoporosis. But if the T-score between -1 and -2.5, we need to do a FRAX assessment for him to check the probability of hip fracture or non-vertebral fracture. If more than 3% and if more than 20%, he needs treatment. Drug treatment, the best medicine, and the first medicine we use, bisphosphonate. Bisphosphonate is called anti-resorptive, decrease the destruction of the bone. We use it orally once a week, or also there is IV injection once a year. But the problem, there is flu-like illness occur in about 10% of cases. Apandronate is once monthly, but it's not cover the non-vertebral fracture. If the patient is not tolerate the tablet, because the most important things, there is no problem in the stomach or esophagus. Or when we prescribe this medicine, we need to tell the patient that he need to upright position for half an hour and not eat any food, only the water. But some patient is not compliant for this. So it's easy to start another medicine, subacute injection, which called denosumab. It's one every 6 months. And it's friendly for the kidney, and there is no side effect for the stomach or esophagus.
Doctor, you have 3 minutes.
Okay. If the patient, he has a fracture during treatment, so we need to change the medicine to anabolic medication. This is antiresorptive. Anabolic medication, we have parathyroid analog hormone. This need to take it for only 2 years. This is subcutaneous injection once a day. But the problem, there is increased incidence of osteosarcoma, so it's not to use more than 2 years. Nowadays, we have romosozumab. This is once a month subcutaneous injection, but the problem is not offered for patient with MI. It's not used more than 1 year, but after 1 year, we need to return to the antiresorptive medication. All the medicine for anti-osteoporotic, it's increased incidence of osteonecrosis, but it's very rare. It's occur between one, more than, very, very rare. واحد بال10,000 or واحد من 100,000 cases. But the problem, the patient concentrate on this. So we prevent the fractures by more than many cases, but the only small number, very small number of osteonecrosis of the atypical fracture within 5 years or atypical fracture for 10 years. But the problem, the patient afraid from this condition. This is osteonecrosis of the jaw. It's very, very rare. It's occur in patient with diabetes, with history of cancer, with patient take steroid. This is the medicine, antiresorptive and anabolic. Antiresorptive, as I said, bisphosphonate, and denosumab, anabolic, teriparatide, and romosozumab. Antiresorptive is used in patients with history of cancer. Common concern about the medication, I prefer natural remedies. I heard from many patients this, I need to take calcium, vitamin. No, we need to prevent the fracture now. We need to take medicine. I am very sensitive to medication. I've read that osteoporosis medication can be dangerous. I have mother, sister, and friend that took this medication and had a unpleasant side effect. Take-home message, fracture due to osteoporosis are serious but preventable. Osteoporosis affect men and women. Fracture risk depend on many factors. Lifestyle is very important. Can slow but not reverse the bone loss. When used properly, osteoporosis medication are safe and effective. Thanks a lot.
Yeah, thank you so much, Dr. Abdamir, and for amazing talk. Sorry? Yeah, so it seems we are running out of time. But Dr. Yahya, you have one question?
Sorry to disturb the program, but for Dr. Mustafa or Dr. Abdelamir, comment. Dr. Mustafa, just commenting on your excellent presentation, but I know you don't have time. But because you are talking about biological treatment for SLE, and please correct me if I am wrong, there are recent evidence that in both osteoporosis and SLE, the use of regenerative medicine. In SLE, there are quite few case reports of use of stem cell, which I have seen these cases. It gives excellent result. And in osteoporosis, there are one study which showed that stem cell therapy improve the whatever score and decrease the number of fracture. It is a comment, but if you want to, I love to hear your comment. Thank you.
Thanks, Dr. Yahya. Actually, yes, the correlation between SLE and osteoporosis is mainly being, an inflammatory disease, inflammatory burden. At the same time, actually, it's the steroid effect. So, yes, definitely. And then, as you mentioned, now stem cells are used for refractory cases of lupus. This is called the CAR T cells therapy, which is now adopted. Thank you.
Yeah, thank you so much. Yeah, just one question, please.
Thanks for the nice presentation. It's a question for Dr. Falah. Very good overview about breast cancer. It's just regarding the, we're all heading towards the prevention rather than cure. So I just want to inquire.
I cannot hear you.
Can you hear me now? Yeah. Yep. So it's regarding the prevention of breast cancer. So, BRCA trial talking about denosumab and its effect on the BRCA mutation positive. Is that something that you would explore? It's on a phase 3 trial, it's in the States, and it's a big thing.
I can't hear clearly, sorry.
It's about denosumab as phase 3 trial.
Yeah.
Yeah, so is that something that you would start as a preventing for breast cancer, or is something,
Yeah, for postmenopausal women or those who are on aromatase inhibitor, we do that. We give them 6 monthly denosumab in addition to vitamin D and calcium and zinc, which is the osteocare does, and of course advise exercise. But we do that as a preventive, yes.
Thank you, Dr. Falah.
Yeah, thank you so much. It seems we are running too much out of time, so we will proceed for the last step. We give the certificate for our professors.
The first one, Professor Dr. Abdelbaqi Al-Khatib. Professor Dr. Mustafa Al-Azzi.
والصيف وايام الخريف الطرب والغي يلعب بالصبي والثقيل يكون في الغيا خفيف. الذي في العين راح ابو ظبي في وداع الله يا ذاك الوليف النياك الدار طبعه يتعبي والوحيد يعيش دايم مستخيف. الذي في العين راح ابو ظبي في وداع الله يا ذاك الوليف النياك الدار طبعه يتعبي والوحيد يعيش دايم مستخيف. يا عيوني وين هذاك الطبي خزني بالعين وادعاني تلف. يا عباد الله هذا صاحبي ولا انا غلطان في الجنس اللطيف. يا عيوني وين هذاك الطبي خزني بالعين وادعاني تلف. يا عباد الله هذا صاحبي ولا انا غلطان في الجنس اللطيف. ما بغيت احباب دون حبيبي ولا بغيت انسان من دون حليف. عذب المشتاق صوت الراعبي لين طاح الدم عمال الدريف. ما بغيت احباب دون حبيبي ولا بغيت انسان من دون حليف. عذب المشتاق صوت الراعبي لين طاح الدم عمال الدريف. من بحر 90 ضاوي مركبي جايب النانات والدر النظيف. يا اهل الغياط صلوا على النبي اللي محتو شي ما مثله وصيف. من بحر 90 ضاوي مركبي جايب النانات والدر النظيف. يا اهل الغياط صلوا على النبي اللي محتو شي ما مثله وصيف. المزام اليود زين العقربي بالشتاء والصيف وايام الخريف الطرب والغي يلعب بالصبي والثقيل يكون في الغيا خفيف. المزام اليود زين العقربي بالشتاء والصيف وايام الخريف الطرب والغي يلعب بالصبي والثقيل يكون في الغيا الدار طبعه يتعبي والوحيد يعيش دايم مستخيل. يا عيوني وين هذاك الطبي خزني بالعين وادعاني تنيم. يا عباد الله هذا صاحبي ولا انا غلطان في الجنس اللطيف. يا عيوني وين هذاك الطبي خزني بالعين وادعاني تنيم. يا عباد الله هذا صاحبي ولا انا غلطان في الجنس اللطيف. ما بغيت احباب دون حبيبي ولا بغيت انسان من دون حليف. عذب المشتاق صوت راعبي لين طاح الدم عمال الذريف. ما بغيت احباب دون حبيبي ولا بغيت انسان من دون حليف. عذب المشتاق صوت راعبي لين طاح الدم عمال الذريف.
يحيي بما يعطي جميع الأحياء. مؤتمر العلمي مع الأطباء يحيي بما يعطي جميع الأحياء. ولدور العراقي طعم آخر، ولدور العراقي طعم آخر يحيي ودور رائد بناء من بلد النخيل والنهرين والتاريخ والبقاء والفرات إذ لا إحصاء. من بلد العلم إلى بوتقة العلم الإمارات مع الأشقاء. دبي صارت موطنا مقدرا لنا ولم شمل هذه الأسماء. تلك الإمارات التي تجمعنا سباقة في كل فن قد جاء. حي العراقيين، حي العراقيين من تصدروا. الله ما يفعله الأطباء. يعطون من فيض الدواء حبهم حتى يحاصروا به فوضى الداء. ويمنح المرضى الحياة والهنا حتى يكونوا بيننا أصحاء. تلك الإمارات التي قد رتبت لعقارات الغيم كل استسقاء ما يجعل الحياة لونا آخرا حيا وتسقي عطش الأرض الماء. مشكورة جهودهم وبذلهم، والبذل في العلم دليل الإنماء. والعلم والدولة شيئان إذا تكاملا حتما ستأتي أشياء. أشكر جهد من لنا قد بذلوا، من نظموا كلا بدون استثناء. لكن أخص مريما بالتمطر دكتورة استاذة وشماء. وأشكر المؤتمر الفذ الذي عرفنا بكل وجه وضاء. مني من الريف مؤمن لكم محبة مثل النقاء بيضاء. من مؤمن الريف كل دعوة مرفوعة للكل خير دعاء. والسلام عليكم ورحمة الله.